Hello everyone, I'm Dr. Hemangini Zala, doing fellowship in fetal medicine under Dr. Jayaprakash Shah at Rajani Fetal Medicine Center, Ahmedabad. Today I'm going to present a case under the guidance of my sir. So this is a patient, Mrs. XYZ, 30-year-old, primigravida, spontaneous conception, non-consanguineous marriage, no specific personal or family history. Her first trimester scan was done, which was absolutely normal. Came to us for her TIFA scan at 22 weeks. In that scan, we saw that the heart was pushed to the right side. So we evaluated her heart in all the views and it was absolutely normal. So we looked to the lungs. So right side of the lung was absolutely normal, but the left side of lung there was a homogeneous hyperechoic mass compared to the rest of the lung and compared to the right lung. And this mass was supplied by the pulmonary artery as it is seen in the image. We also ruled out peristalsis in the mass, and also the diaphragm was intact. So congenital diaphragmatic hernia was ruled out in this way. Also there were no other fetal abnormalities. So the diagnosis was made as microcystic CPAM. We calculated the diameters and the length and the width of that mass according to the formula given on perinatology.com, and the CVR ratio came to be less than 1.6. Also there were no signs of high drops at this time, so patient was counseled about the good outcome of this microcystic CPAM, and agreed to continue with the pregnancy. Patient was asked to follow up every 2 weeks, and at that time we used to calculate the CPAM, and we calculated the CVR ratio, which was consistently less than 1.6, and every time there were no signs of high drops. So we did this till 26 weeks of pregnancy, and after that patient was asked to follow up monthly because there were no signs of high drops. Also the CVR was consistently less than 1.6. So for now on there are no risk of developing high drops in CPAM. So now the patient came at 30 weeks of gestation, in which the sonographic findings showed that there was mesocardia, but the CPAM was not seen on USG in the axial view of the mediastinum. It was suspected that it has either regressed or it has become isogenic to the rest of the normal lung. Color Doppler growth and the Leica were absolutely normal. So the patient was followed up routinely every month and was seen for the growth of the fetus. And now the patient is almost 38 weeks and is going to deliver. Coming to the discussion part, these are the conditions in which we see dextroposition and mesocardia. Dextroposition is seen with left-sided congenital diaphragmatic hernia, CPAM, pulmonary sequestration, right lung agenesis or hypoplasia, and induplication cyst, while mesocardia is seen in DORV, transposition of great arteries, AVSD, common atrium, isomerism, and chaos. Coming to the discussion part of CPAM, CPAM is congenital pulmonary airway malformation. Previously it was known as CCAM, that is congenital cystic adenomatoid malformation of the lung. It is a hematomatous lesion characterized by mass of disordered pulmonary bronchioles and lack of normal alveoli. It is a developmental anomaly with abnormal branching of immature bronchioles which communicate with the normal tracheobronchial tree and derives the blood supply from the normal pulmonary circulation. Incidence is 1 in 25,000 to 35,000 live births, and it is more common in males. It can affect any lobe of the lung. It is usually unilateral unilobular in 80 to 95% of the cases, and in fewer than 2% of cases it is bilateral. This lesion develops during the pseudoglandular period at 7 to 16 weeks of gestation. What normally occurs during pseudoglandular period is there is branching of the primary lung bud into bronchial tree, which develops up to the level of terminal bronchioles. So insult during this stage decreases the number of bronchial trees with or without overgrowth of the lining cells, leading to CPAM. Etiology is unknown, but as I said, it is a developmental anomaly and it is a benign growth of the tissue. Coming to the pathogenesis, it prevents the healthy lung tissue to develop, leading to pulmonary hypoplasia. Also, it pushes on the heart and the large vessels, leading to central venous compression, which leads to fetal height drops. Fetal height drops may also be exacerbated by the loss of proteins from the CPAM into the amniotic fluid, thus reducing the fetal colloid oncotic pressure from hypoproteinemia. CPAM is also found to be associated with pulmonary sequestration and segmental bronchial atresia as a common pathogenetic mechanism. So in this figure, we can see a left-sided CPAM which is compressing the lung. Also, it is depressing the diaphragm and shifting the heart to the opposite side, leading to venous compression, which leads to ascites, placentomegaly, and non-immune hydrops. Coming to the classification part, it was classified by Stoker by its histology, and it was classified into three types. Type 1 is large cyst of a cyst size of 2 to 10 centimeter. Type 2 small cyst, cyst size of 0.5 to 2 centimeter, and type 3 is solid or microcystic, cyst size of less than 0.5 centimeter. The Stoker revised its classification and it was classified according to the site of insult during its embryogenesis, which is leading to CPAM. So it was classified into 5 types. Type 0, the site of insult was trachea and proximal bronchus. Type 2, which is most common, the type of insult is distal bronchus and the proximal bronchiole. Type 2, the site of insult is terminal bronchioles. Type 4, it is near the alveolus, and in type 4, it is in the alveoli. But by Stoker's classification, we can't classify CPAM by ultrasonography. So, Adzik et al. Classified it by ultrasonography, and it was classified into 2 types. Type 1 is cystic, and type 2 is solid or microcystic. In cystic, there are multilocular lesions with multiple cysts of more than 5 mm, or either there is a dominant cyst and a peripherally arranged small cyst. In type 2, the cyst size is less than 0.5 mm, so it appears as a well-defined homogeneous hyperechoic mass on ultrasonography, but it has a high risk for height drops and pulmonary hypoplasia. USG findings are like these: solid or cystic mass in the lung, increased echogenicity of the mass compared to the surrounding normal lung tissue and the opposite lung tissue. Usually it is unilateral, confined to single lobe of the lung, and mostly it affects the lower lung fields. Cyst wall has a brighter contour. There is contralateral shift in the axis of the heart. Abdomen is of normal shape. There is no peristalsis in the mass. Polyhydramnios is seen later in later stages of the pregnancies due to esophageal compression by the lesion or increased fluid collection by the abnormal lung. And in some cases there is height drops. Hybrid CPAM, it is a CPAM with anomalous arterial and venous drainage. Hybrid CPAM has systemic blood supply that is directly from the descending aorta. It has features of both CPAM and bronchopulmonary sequestrations, and the natural history was also a mixture of 2 lesions. It can't be differentiated by ultrasonography that it is CPAM or it is hybrid CPAM, but the anyways, the prognosis of CPAM and hybrid CPAM are the same, and it is favorable. Natural history. It is an evolving lesion with peculiar features. There is rapid growth of the mass between 20 to 26 weeks of gestation. Then the volume of the mass plateaus, and then the mass regresses in 10 to 20% of the cases, or it sonographically disappears during the third trimester and is called vanished lesion. In third trimester, the mass becomes isoecogenic to the adjacent normal lung parenchyma and can only be detected by MRI. After 26 weeks, it is unlikely to develop hydrops if not developed yet. The reason for regression of fetal CPAM is not understood, but it is possibly suggested that the mechanism is decompression of the fluid from CPAM into the tracheobronchial tree or outgrowing of its blood supply. There are no biochemical or sonographic markers that allow differentiation between a CPAM that will regress and the one that will progress to hydrop. A differential diagnosis are bronchopulmonary sequestration, but in this the appearance is the same as microcystic CPAM, but the feeding vessel is descending aorta. Right-sided CDH with lever up, it has weak echogenicity, but in CPAM there is bright appearance. Also in liver the portal vessels are seen. In neuroblastoma also has less echogenicity compared to microcystic CPAM. Left-sided CDH, there is peristalsis in the loop of the herniated bowel, or if the stomach is herniated through the diaphragm, there will be stomach emptying seen. But while in macrocystic CPAM, the cyst wall is echogenic, plus the cyst size does not changes. Bronchogenic cyst, it is unilocular and is usually adjacent to the major bronchi, which may be confused with type 1 CPAM, which has echogenic cyst wall. Associated malformations are congenital diaphragmatic hernia, tracheoesophageal fistula, pulmonary artery branching abnormalities, renal agenesis, bowel atresia, truncus arteriosus, tetralogy of Fallot, hydrocephalus, and skeletal abnormalities. Chromosomal abnormalities risk is low, but it slightly increases if there is associated extrapulmonary malformations. Risk of non-chromosomal abnormalities are prognostic indicator. It is calculated by calculating the CVR, and the CVR is calculated by calculating the CPAM value, and then it is divided by the head circumference. So CVR is calculated by calculating the length of the maximum length of the CPAM mass, and 90 degree to it the width is taken, and then rotating the probe 90 degree to that view the depth is taken, and it is calculated by 0.52. CVR ratio is helpful for diagnosing the possibility of developing hydrops at the time of diagnosis and during the follow-up, and the presence of respiratory symptoms at birth. If the CVR is less than 1.6, there is 2.3% chance of developing hydrops, but if there is a dominant cyst in that CPAM, there is 17% chances of developing hydrops. When CVR is more than 1.6, there are 75% chances of hydrops with or without presence of dominant cyst. Obstetric management. We have to confirm the diagnosis, its blood supply, and the size of the cyst. We have to look if there is a mediastinal shift. Also, fetal echocardiography is done to rule out the associated cardiac problems. Calculate the CVR, search for early signs of hydrops, genetic study if there are associated other extrapulmonary malformations, counseling if the CVR is less than 1.6, it has a good outcome, and there are high chances of spontaneous regression of CPAM. Obstetric management. Follow-ups are done to look for the size of the lesion and to look for pulmonary hypoplasia. During each follow-up, we have to calculate the CVR. If it is less than 1.2, there are least chances of hydrops and follow-up is done fortnightly. If CVR is 1.2 to 1.6, moderate chances of developing hydrops and weekly follow-up is done. If it is more than 1.6, there are high chance of developing hydrops and twice weekly follow-up is done. Dominant cyst, even if the CVR is less than 1.6, fetus is at high risk for acute enlargement of the cyst and development of hydrops. So thoracoamniotic shunt is done at the earliest sign of hydrops. Delivery is done at tertiary center if CVR is more than 1 at any point during the pregnancy, because there would be a possible need for neonatal respiratory support to the newborn with potentially severe pulmonary hypoplasia. There is no need for cesarean delivery of a baby with CPAM except for standard obstetrical indication. Mirror syndrome. It is a hypodynamic pre-eclamptic state which is life-threatening, and it is seen in mother with fetus with CPAM. It is also seen in molar pregnancy, sacrococcygeal teratoma, and in fetal conditions that result in poor placental perfusions which lead to endothelial cell injury. The only treatment is immediate delivery of baby and placenta. Antenatal treatment. In cases with macrocystic CPAM, we can either do cyst aspiration of the dominant cyst or thoracoamniotic shunting can be done, but it relies on the fact that all the cysts are communicating with each other, and it is done in cases with hydrops prior to 32 weeks. For microcystic CPAM, we can either do open fetal surgery in cases of large microcystic CPAM with hydrops. In these cases, maternal steroids are given prior to the surgery for arresting the growth of the fetus, or and also because there is high risk of preterm mother going into preterm labor pain in these cases. Steroids are given for regression of the microcystic CPAM cases. 12 mg betamethasone is given 24 hours apart, maximum 2 doses. It is given when there is a large microcystic CPAM with hydrops or when CPAM with CVR is more than 1.6. It induces early growth plateau, and there is reversal of hydrops in 78% of cases, and there is 73% survival rate in a study. In that study, in few cases where there was CVR more than 1.6, the hydrops did not develop, but the study is still going on for the ideal timing, dose and selection of the candidate for steroid therapy. It is thought that steroids may arrest the growth. It is not proven that steroids truly affect the growth of the CPAM. Delivery by exit to resection is done in CPAM with significant mediastinal shift and cardiac compression. In this, thoracostomy is done for resection of CPAM on placental support during an exit procedure. In this approach, when the infant is born, the trachea is decompressed, facilitating ventilation, and if ECMO is needed, venous return will be unobstructed. Treatment of the newborn. Delivery in tertiary center. As there is a need for immediate resuscitation in case of pulmonary hypoplasia, and there will be need of ECMO. After delivery, evaluate the newborn to confirm the diagnosis and exclude other associated anomalies. CT or MRI is done to look for the residual CPAM tissue. Infant different with type 1 and type 2 CPAM, there is risk for air trapping, which would acutely worsen the respiratory status. In unilateral CPAM, selective intubation of the contralateral bronchus may be useful temporizing measure until resection of the CPAM can be accomplished. Pneumothorax is an additional concern in CPAM type 1 and type 2 lesion and may require tube thoracostomy. Long-term outcome following resection are excellent. The complete resection of CPAM by lobectomy is done immediately after birth if it is symptomatic. But if it is asymptomatic, the resection of the non-functioning lobe can be done by 12 months of age. If the residual CPAM is left behind or the mass is not resected, there are risks for infections, recurrent infections, and there are chances of malignancy, which is very less, but yes, still it is. Benefits of resection is the remaining lung will undergo significant compensatory growth within months of surgery with continued alveolization for several years. This will not occur if the CPAM is left in situ. And the risk of resection are in extensive involvement of nearly the entire lung, the resection of multiple lobes or pneumectomy may be necessary. This will lead to lethal problems in the newborn like mediastinal shift, vascular compression of the trachea and the remaining bronchus. So in these cases, non-anatomic resection is done to preserve as much as normal pulmonary parenchyma as possible to allow post-operative compensatory growth and avoid post-pneumectomy complications. In CPAM, which are undiagnosed antenatally, the postnatal natural history will be like it would be asymptomatic at birth and it will come in picture accidentally on X-ray when it is done in cases of recurrent respiratory infections, or the CPAM will lead to severe respiratory distress at birth due to pulmonary hypoplasia. In both these cases, it is suggested to resect the CPAM. Prognosis: if there is no hydrops developed during the entire period, the survival is unaffected and there is no functional limitation regardless of the possible need for lobectomy. The overall survival is 80%. If hydrops have developed, there are increased chances of neonatal death and intrauterine treatment is not much useful. So the only take-home message is whenever we see the axial view of the mediastinum, it is very important to see the lungs along with the heart. We give so much importance to the heart that sometimes we miss the lungs, which may be abnormal in few cases. Thank you.